Right here, in the front of your neck, you've got this small, butterfly-shaped gland that runs your entire metabolism. It's your thyroid. But what happens when it goes wrong? When it gets too big, becomes overactive, or worse, develops cancer? Well, sometimes it has to come out. Today, we're doing a deep dive into that very procedure, the thyroidectomy.
So, here's what we're going to cover. We'll kick things off with why this surgery is even necessary. Then we'll walk through all the prep work. After that, we'll go inside the OR step by step. Then comes the serious part, navigating the risks. And finally, we'll look at what life is like after the thyroid is gone.
All right, first things first. Why would a surgeon decide to remove all or even just part of this incredibly important little gland?
Well, look at this. This is one of the biggest reasons. It's called a retrosternal goiter. The thyroid has grown so massive that it's actually extending down into the chest. And as you can imagine, that puts a ton of pressure on everything around it. Your windpipe, your major blood vessels. It's not just big, it's dangerous.
So the reasons for surgery are pretty specific. You've got what are called toxic nodules, basically overactive lumps that medication just can't control. You've got the huge goiters like the one we just saw, which can make it hard to even breathe. And then, of course, the big one, any suspicion of cancer. That makes surgery a top priority.
Now, you don't just rush into a surgery this delicate. No way. Careful, methodical preparation is absolutely non-negotiable if you want a safe and successful outcome. So, let's see what that actually involves.
The whole game here is to get the patient's body into a calm, stable state, what we call a euthyroid state. So you use antithyroid drugs to quiet the gland down, beta blockers like Indirol to get the heart rate under control, and then there's this really clever trick. For about 2 weeks before the operation, you give the patient something called Lugol's iodine. It does two incredible things. It shrinks the gland and it seriously cuts down its blood supply. For a surgeon, that is a huge advantage.
Okay, preparation's done. The patient is ready. Let's pull back the curtain and break down what actually happens inside the OR.
So, a thyroidectomy isn't just one single operation. It's more like a spectrum of procedures, tailored to exactly what the patient needs. It can be as simple as taking out one lobe. That's a hemithyroidectomy, all the way to taking out the entire gland. But here's a really key surgical principle. No matter which of these procedures is done, that central connecting piece, the isthmus, and any associated tissue, it always comes out.
You know, the choice between a subtotal and a total removal is a really critical trade-off. With a subtotal, especially for a toxic goiter, the surgeon might leave a tiny piece of the gland behind. The hope is that it'll produce just enough hormone to keep you off medication for life. But the disease can come back. On the other hand, you can do a total thyroidectomy, take it all out. You are guaranteed to need hormone replacement pills forever, but you've also completely eliminated the risk of the problem coming back in that spot.
So how do they actually get in there? Well, it starts with what's called a Kocher's collar incision. It's a very clever cut placed right in a natural skin crease so that when it heals, the scar is barely visible. From there, it's a careful dissection down through the layers, moving aside these strap-like muscles to get to the gland. Now, if they're dealing with a really massive goiter or a suspected cancer, they might actually have to cut those muscles to get the exposure they need.
And this gets right to the heart of why this surgery is so challenging. The thyroid is swimming in blood vessels, and they are tangled up with tiny but absolutely critical nerves. You see that little nerve there? That's the external laryngeal nerve. It's what controls the pitch of your voice. One wrong move, and it's damaged. So yeah, protecting these little structures is everything.
Okay, this is fascinating. There's a very specific, deliberate sequence for tying off the blood supply. It's not random. It's like a carefully planned dance for safety. First, the middle thyroid vein. You have to get that one first because if it tears, you could get a deadly air embolism. So rule 1, secure the vein. Next, you tie off the vessels at the top, but you do it close to the gland to stay away from that external laryngeal nerve. Then you tie off the artery at the bottom, but this time you do it far from the gland to protect a different critical nerve, the recurrent laryngeal nerve. Then you finish with the veins at the very bottom. See, every single step has a vital reason.
All right, we've seen how it's done, but like any major surgery, things can go wrong. And because of where the thyroid is, the potential complications are pretty serious. Bleeding is a top concern. The one that keeps everyone on high alert is called reactionary hemorrhage. This happens within the first 24 hours after surgery. What's usually happened is a stitch has slipped off the superior thyroid artery, and blood is now pooling rapidly in the neck. And this quote, wow, it tells you exactly how terrifying that situation is.
That collection of blood, that hematoma, is squeezing the windpipe shut. The patient can't breathe. It is such an emergency that you don't even have time to get them to an operating room. The first move is to open the wound right there at the bedside to release that pressure. That's how fast you have to act.
Okay, nerve injury. This is absolutely critical. Damage to that recurrent laryngeal nerve can have dramatically different outcomes. If you injure one side, you might get a hoarse voice. But, and this is every surgeon's nightmare, if you have an incomplete injury to both sides, both vocal cords slam shut in the middle. The airway closes off, the patient starts making a high-pitched sound called stridor, and they are suffocating. This is a life-or-death emergency that needs an immediate tracheostomy.
Now, this next one is rare, but it's incredibly dangerous. It's called a thyroid storm. The surgery itself can trigger a massive flood of thyroid hormones into the body, sending every system into overdrive. The 5 H's help us remember it: hyperthermia, a raging fever; hypertension, sky-high blood pressure; a super high heart rate; heart failure; and hyperexcitability. This is a true medical emergency, and you have to treat it aggressively.
Remember how crowded it is in the neck? Well, hiding behind the thyroid are 4 tiny glands, about the size of a grain of rice, called the parathyroids. They control your body's calcium. If they get bruised or accidentally removed during surgery, calcium levels can crash. This leads to a condition called tetany, numbness, tingling, muscle cramps, and in severe cases, dangerous spasms. The treatment is an urgent IV of calcium gluconate.
And the list of potential issues goes on. You can injure that other nerve, the external laryngeal nerve, which affects your voice's pitch. If too much tissue is removed, you can get permanent hypothyroidism. And get this, if you remove a massive goiter that's been pressing on the trachea for years, the trachea itself can be weakened and actually collapse. It's called tracheomalacia. It just reinforces how much skill and precision this surgery demands.
So after all of that, after the surgery is done and the patient is through recovery, what does life look like? What's the road ahead?
The takeaway is actually pretty simple. If your thyroid is gone, its hormones have to be replaced. For patients who've had a total or near total removal, taking a hormone replacement pill every day is a lifelong necessity. But that one little pill does the job of the thyroid perfectly, regulates metabolism, and allows them to live a completely normal, healthy life.
And that kind of leaves us with one final thought. This delicate surgery has saved countless lives, and the techniques just keep getting better. But maybe the next real frontier isn't just perfecting the surgery, it's finding ways to treat the underlying autoimmune diseases, the nodules, and the cancers that make a person need to go to the operating room in the first place.